I have defined or put in some objectives for you on this talk, and they are, by the end of this lecture, you should be able to define nutritional support or nutritional support therapy. You should be able to describe the main methods used for nutritional support, and you should be able to outline how to assess an individual who has malnutrition prior to giving them nutritional support. And then we are going to talk about the major nutritional support, parenteral nutrition. Okay, so what is nutritional support therapy? One thing we must know that all people need to feed in order to live. Sometimes an individual cannot eat any or enough food because of a particular illness. The stomach or the bowel may not be working properly, or the individual may have had surgery to remove part of all, also part or all of these organs. Under such circumstances, the nutrition must be supplied in a different way. And that supply in a different way is what we call nutritional support. It's given. Nutritional support can be provided through, it can be provided through a feeding tube, or when the gastric tract cannot be used, it can be supplied through an intravenous tube. And an intravenous tube is a catheter which is inserted directly into a vein, and this is parenteral nutrition. So nutritional support can either be enteral, which is through a tube, or parenteral, which is through a catheter in a vein. So the amount, type, and route of nutrition are tailored specifically to each patient's requirement. So the main nutritional support is to improve a patient's outcomes, minimize infections, and allow them to live their lives normally. So nutritional support is just like feeding people in order to, alternatively, in order to let them live like any other normal individual. What are the types of nutritional support? And I've just told you that there are two main types. One is enteral and the other one is parenteral. The enteral nutrition is a way in which individuals can receive the nutrition they need through a tube into the stomach or other parts of the GI tract, okay? Other parts of the intestine, okay? And it's also sometimes called tube feeding. Enteral feeding is a feeding in which a mixture of substances, all nutrients needed, are supplied through a tube. And parenteral nutrition, and it sometimes looks like milkshake or yogurt. So these patients who have got tube feeding, they get food in a more concentrated manner. Parenteral nutrition is the way by which individuals receive nutrition when they cannot eat or use their GI tract, okay? Eat, meaning doing it by yourself, or using the GI tract is by using a tube. It's a special liquid. It is in this feeding, a special liquid mixture is given through the bloodstream, through an intravenous tube. So the mixture contains all nutrients, and they are proteins, sugars, fats, vitamins, minerals, okay? And any other things needed. Sometimes water is added to these things. This is also called total parenteral nutrition. Total parenteral nutrition has got this old title called hyperalimentation. Hyperalimentation does not mean feeding too much. It is feeding through the parenteral route. The provision of enteral or parenteral nutrients to treat malnutrition. This is called nutritional support therapy. Nutritional support therapy is part of the nutritional therapy, which is part of the medical treatment. Okay, so patients who are in the wards, well, besides getting drugs, they also get food, and this food is also part of the medical scheme. So the support can include oral feeding. It can include enteral, maintain or restore normal nutrition to give a normal nutritional status or health. So nutritional therapy is a medical treatment in which food is applied to acquire the original optimal functioning individual who has no illness and has no malnutrition. How do we assess the individuals who require nutritional therapy? First of all, the individuals who require nutritional therapy have a malnutrition, okay? And malnutrition can be a disease by itself, or it can be part of a disease process, in which case an individual who is suffering from, say, a pneumonia has an inability to accumulate or to acquire enough normal nutrition. So we must give them nutritional support. So when you want to start nutritional support therapy, we must assess these individuals. And the assessment first is done by weight, the weight of the individual. If greater than 10%, weight loss, if greater than 10% of the normal body weight, then we consider that fellow malnourished, okay? And they may have decreased food intake, and they also can have symptoms, okay? So the history will give you a weight loss greater than 10%, okay? It will also give you that these patients have had symptoms like anorexia, dysphagia, nausea, chronic diarrhea, or abdominal pain. In this person who has more than 10% body weight, these symptoms may have occurred in the history. The second means of assessment is by physical findings. When the patients are with you, you examine them and their weight is less than 90% of an ideal weight, for their age. We can also do anthropometric measurements for this individual, and the usual one is the mid-arm circumference or loss of subcutaneous fat. And here we look for thicknesses of the skin fold, and we can also look for disease patterns that occur with malnutrition, like skin rashes or ocular changes, okay? And we have mucous membrane changes for deficiencies. We have neurological changes for particular diseases. So in physical examination, we are able to identify what are associated with malnutrition in these individuals. The third way of assessing malnutrition is by using the laboratory. In the laboratory, we measure the serum albumin. And if the serum albumin is less than 30 grams per liter in that individual, then they are malnourished, okay? The total lymphocyte count less than 1,800 per cubic millimeter tells you that this patient is immune deficient. Skin test reactivity assess the levels of the vitamin, plasma level of iron or folic acid, serum levels of zinc, magnesium, and phosphorus. Are we still together?
Yes, Dr. Wandolo, we're together.
Yeah, this fellow is warning me that I have an unstable network. So we are on third assessment. So we started by history, and then we got to physical examination, and then we're now on the laboratory. The next one is special methods. We have special methods for assessing nutrition. And one of these special methods is called bioelectric impedance analysis, BIA. And this measures total body fat. It can also measure fat-free mass. It can also measure total body water. We can also measure by this special methods, we can also measure the lean body mass. And the lean body mass is the body weight minus the fat, and the fat we have measured in the first one up there. And 73 gives you what is called the lean body mass. Total body water divided by 0.73 gives you that the lean body mass. Okay, so these are things we measure before we give people nutritional support. We also have indirect measurements for nutrition. And indirect measurements are those that are called indirect calorimetry. And indirect calorimetry measures what is called resting energy expenditure. And there's a Harris formula there. If you want to go through it, it's up to you. If you want to be a nutritionist, this Harris formula must be there, must be part of your daily duties, okay? I don't want to go through it, but I'm telling you that a nutritional assessment can also be done by measuring what is called a resting energy expenditure, okay? So we have also energy-based equations like Schofield equations for estimating metabolic rates. We have also Schofield equations that allow us to estimate the basal metabolic rates. Okay, so these are equations. Now let me go back a little. So here, methods or procedures, we have BIA. We have in BIA, we have BIA, and then we have the lean body mass, okay? And then we have indirect calorimetry, in which we have resting energy expenditure. Then we have these other little things which we do under the calorimetry, indirect calorimetry. We also have energy based on Schofield equations. We have the Schofield equation that allows you to measure the BMR. Okay. And then we have nitrogen balance. Nitrogen balance can also be used. Okay. And nitrogen balance is nitrogen input minus nitrogen output. So 1 gram of nitrogen is given there, and the total nitrogen in protein is that times 0.25. Okay. So the input for 24 hours and the urinary nitrogen is equal to urinary nitrogen plus non-urinary nitrogen, which are estimated. These are the things that if you want to get into nutrition, you must know. But remember that in assessment of nutritional requirement, we can also measure nitrogen balance. Okay, so this equation, if you want to study it properly, it's up to you. But remember that it is a measure of the protein quantity. Finally, before we start people on nutritional management or support, we must do the general laboratory workup. A complete blood count, liver function tests, renal function tests, serum electrolytes, which are probably part of the renal function test. Do a prothrombin time and partial thromboplastic time. Then we do a lipid profile. So this is before we start somebody on nutritional support. Yeah. I'll go back here. Go back. Now we must assess the nutrition of an individual before we give them nutritional support. And to do that, we go by history, we go by physical findings, we go by laboratory measurements, we go by special procedures, special methods, and then we do a basic assessment before we start them on treatment. Okay, are we still together?
Yes, yes, yes.
Okay. Now, what is it that we do in nutritional support? Now I'll go straight to parenteral nutrition. Parenteral nutrition is defined as intravenous administration of calories, nitrogen, and other nutrients in sufficient quantities to achieve tissue synthesis and anabolism. Okay? So this is parenteral nutrition. So we give as much as is required to maintain cellular life. Now, historically, until the early 60s, the use of intravenous nutrition was restricted to high concentration of dextrose and electrolytes. In 1962, Retland and his colleagues developed lipid infusions as principal source of calories for parenteral feeding. So this came as an addition even before the 60s, and after the 60s, we can now add, instead of just dextrose, we could now add lipids. Okay? In 1966, there's a development of parenteral nutrition, and parenteral nutrition now contained all the materials that we need as food, and this was done for a person who had no small bowel. Okay? So they were still able to feed like any other normal person, but now through a vein. So in 1976, this fellow called Solasol and Joyax developed the 3-in-1 mixture by putting sugar, lipid, and amino acids in a single bag. So now some people could buy a bag containing their food, and that food was sugar, lipids, and in a single bag, okay? And in 1978, this single bag could now be used at home, okay? So you didn't have to go to hospital in order to be given the total parenteral nutrition in the hospital, but you could carry the bag and do this thing at home. So from 78 onwards, now parenteral nutrition became an easy thing to do. So you didn't have to confine individuals to a hospital to give them nutritional support. The parenteral nutrition uses a vascular system to provide vital nutritional support to malnourished individuals. The nutrients supplied are supplied in their elemental forms: carbohydrates in glucose, lipids in free fatty acids, and amino acids for protein. There are two types of parenteral nutrition. We have, enteral nutrition, parenteral nutrition. We have the total parenteral nutrition, and we have the peripheral parenteral nutrition. And these things can be administered by two routes. Large central veins are used for total parenteral nutrition. Peripheral veins are used for peripheral parenteral nutrition. When is parenteral nutrition required? So when do we need this? It is used to prevent or reduce adverse effects of malnutrition. So the individual must be malnourished. They are used when enteral route is unsafe or ineffective, and that the condition is going to last for more than a week. Okay, so individuals who need parenteral nutrition are malnourished, and that enteral nutrition is not feasible. Okay, and that this condition they have is going to be longer than 1 week. The main indications are extreme short bowel. And extreme short bowels can be due to structural resection of part of the bowel, or it could be functional due to an inflammatory process of the bowel. And then we can give parenteral nutrition when we need the intestines to rest, okay? Like when there is an enterocutaneous fistula, this high output enterocutaneous fistula. When you put food inside, we pour it out into the outside very quickly. And then we have anastomotic leaks. This is after surgery, and we have leaks. Then we must put the bowel to rest. Okay? There's nothing going through the bowel or the ilia or the GI tract. Like when we have a trauma, when we have major surgery or we have trauma, okay? And the other one is when we have intestinal obstruction. And intestinal obstruction can be due to malignancies or to adhesions is following surgery. We cannot give parenteral nutrition when we have coagulopathies. Patients who have coagulopathies, we cannot be able to put any foreign material in their veins. Patients who are hemodynamically unstable, like say patients who have edema, for example. Patients who have pulmonary edema and other fluid overload. Patients who have renal failure are on dialysis. The patients who have and the patients who have advanced cancer or terminal illnesses. This last one is that even if you give them parenteral nutrition, the course of their illness cannot be changed meaningfully. Okay, so you don't have to waste your efforts giving food in a person whose illness is terminal. What are the benefits of this? Is that it turns catabolic state of a patient into anabolic state. Anytime we give enough food, the cells start to rejuvenate. It provides rest to the bowel. This is when we have anastomosis or we have leaks. It prevents muscular wasting. This is when we have carbohydrate deficiency and muscles are now being used as a source of energy. It improves wound healing. Okay, we are supplying requirements for tissue regeneration. How do we perform this? Are we still together?
Yes, Dr. Wandolo, we're together.
Oh, good. Now, these are things that are detailed, and I don't think you need to.
Dr. Wandolo,
Yes?
you stopped speaking.
Okay. Yeah, these are the needs, what we do in parenteral nutrition. First of all, we need to know what are the requirements that we want to give these individuals. The initial part of it is to know how much or what does a person need. And once we know that, we now want to calculate how much to give. So we start with the fluid. And fluid, we must know the basic requirement of any individual. And the basic requirement of fluid in any individual is 1.5 liters. And it's usually 5.5 liters plus 20 milliliters per kilogram body weight of that individual, okay? If the weight is greater than 20 kilograms, the total need must be given minus what is called the basic needs. Basic need plus losses, okay? So whatever we give on top of this is what is called nutritional support fluid. So fluid, a basic need must be given, okay? But if we want to calculate the basic need, we must, first of all, know the total need. And the total need is a need, so total need is the need, is the basic need plus the need, the losses, Okay, the basic needs are above, and the losses are these ones below. So the losses you can be able to calculate, or you can be able to measure. You can measure what you aspirate. You can measure what is the vomited volume. You can measure what is drained. Okay, you can measure what is out of a fistula. Okay, and then you add that to the basic need. So fluid requirement must be a calculation of a total need, and the total need would be the basic need plus what you have calculated as the basic, as the losses. The second one is protein. Okay, the protein requirement is normally 1 to 1.2 grams per kilogram body weight per day. Okay, in catabolic states we give 2 grams per kilogram per body weight. Okay, per day. In catabolic states are when the requirements are increased. And catabolic states include a person who has polytrauma, a person who has severe burns, a person who is taking renal replacement therapy. Okay, so total parenteral nutrition contains amino acid in 3 to 15%. Okay, so when we are calculating the needs, the protein needs, we must know what we have in the solution. So we relate the protein, so the amino acid, the protein requirement to the amino acid concentration in our preparations. Now the next one is energy. Energy requirement is given as 20 to 30 kilocalories per kilogram per day. And this should be provided. Calorie are carbohydrates and lipids. Okay, and this minimizes the use of nitrogenous compounds as a source of energy. Okay, so total energy requirement must be given as either carbohydrate or lipids. Okay, and the ratio of carbohydrate to lipids would be 70 to 30. Okay. Now we have calculated the requirements. So now let me go back again. The requirements for this patient would be fluid requirements, and fluid is calculated, protein requirements, and protein is calculated. And then here, this is non-carbohydrate calorie requirement, which is calculated. So this is the lipid requirements, non-protein calorie requirement, which is calculated as carbohydrate and lipid. Now we must find a venous access for this patient. We have calculated the solutions and made and prepared what we are going to give the patient. Now we must find a route. And the route usually is central. And the central vein should be a large bore, high flow vein. Large bore, high flow vein, or it can be peripheral for parenteral nutrition, and this is for long-term use. And the large bore high flow venous output is one which is usually preferred, and it is for long-term use. Yes, these are the arteries or that the vessels we require: a subclavian, internal jugular, basilic or femoral. These are the veins that we need. If you use this for a very short time, and this and we do this only when we cannot do a central. Okay, central is indicated. Once we have put a cannula, we must verify that the cannula is within the blood vessel. And the cannula can be medium, proximal lumen, and this is for parenteral nutrition. Okay, medial, proximal lumen. Okay, and then we have lateral distal lumen, and this is lateral distal lumen is for other uses. Okay, so the veins have one tip, and that one tip may have two lumina. Peripheral veins can be used, and the peripheral veins, when we use them, we use a simple 23 gauge cannula for peripheral veins. And a venous access can be single lumen, it can be double lumen, or it can be multiple lumina. A double lumen catheter has 2 lumens, while a triple lumen has got 3 of them. Okay, so these are lumens that are used to identify what run several different infusions with only one access. So that access goes into the vein, and outside we have 2 or 3 doors through which we can push the materials. They are often inserted as a short central line with wide inner diameter. Short central line, wide inner diameter. So is short-term infusion, and this is when rapid infusion is intolerable. Continuous for a short term. And when it is cyclic, we use it for long term, okay? And this is when rapid infusion is tolerable. Cyclic, we can do long term, okay? So continuous administration occurs for 8 to 12 hours. And then we give patients rest for 12 hours. And freedom during the day, and we can use 3-in-1 total parenteral nutrition, or 2-in-1 with dextrose, amino acids, lipids, or dextrose given separately. So a 3-in-1 contains all the 3. 2-in-1 contains other dextrose and amino acids, dextrose and lipid. How do we monitor? Now we have put this material into the vein. We are running a tube which contains a solution of our nutrients, and this nutrient is running 8 to 12 hours. How do we monitor these people? We monitor these people by making a daily weight chart or a weekly weight chart. We weigh them regularly, and we have an input-output chart. We know how much we put in the tube, and we know how much we get from the renal output, and we must do the vital signs, blood pressure, temperature, and respiration. And we must do the complete blood count, a renal function test, blood sugar, liver function test, electrolytes, and magnesium. Okay, so electrolytes, blood sugar, and renal function tests are done regularly. Okay, so this is how we monitor a patient who is on this tube feeding, this parenteral tube feeding. What do we watch for? When we give these people parenteral nutrition, anytime we have 2+ glucose in urine, we know we are giving too much glucose. And then when we have ketones in urine, we know we are giving less glucose, okay? Persistent thirst and excessive urine output means we are giving low glucose. Sorry, we're giving too much glucose, okay? Less, the level of consciousness, hypoglycemia, and these are normal routine things that are done within the ward, okay? So if we see chills, rigors, and fever, the patient must be developing an infection. We see signs of phlebitis, then the patient is developing inflammation at the point where you put your catheter. Skin rashes, the patient is allergic to your food, and then hyperventilation and hypotension, the patient is going into fluid overload. So these are things that we watch for. What are the side effects, mainly of lipids? Lipids have got this typical side effect of back and chest pain. They have excessive sweating of an unusual degree, okay? This is lipids. We have fever, we have flushing, we have chills, we have these other symptoms. So lipids mainly give you backache and chest pain. They give you sweating and of an unusual degree. They may give you fever, flushing, and chills and rigors. Complications can be catheter-related, and catheter-related may be an air embolism, a pneumothorax, a hemothorax, cardiac tamponade, and we may injure arteries that are in the vicinity of the vein we are using. We can even injure the thoracic duct and even the brachial plexus. These are injuries or complications that we may create by ourselves. We can also have sepsis, and sepsis is the most common complication, okay? And this is usually life-threatening, and it is of the microorganisms that are usually in our environment, mainly staph epidermidis, or in the skin of the individual, staph aureus in the environment, enterococci, candida, and such like. Metabolic complications of parenteral nutrition include early or nutrient-related complications. And these are hyperglycemia or hypoglycemia, hyperlipidemia or hypolipidemia. And we have a feeding syndrome. Metabolic complications that are late or related to long-term administration include hepatic dysfunction. And hepatic dysfunction can have, we can have steatosis, steatohepatitis, lipidosis, cholestasis, and cirrhosis. We can also have biliary complications, okay? And biliary complications, we have calculus cholecystitis, gallbladder sludge, and cholelithiasis. We can also have metabolic bone disease from osteopenia. Fluid overload can occur, hypo and hypernatremia, hypercalcemia, all the nutrients we have, all the materials we have in the bag. Now, this is the most common complication of the most common complication of hyperalimentation or total of physiological response to glucose reintroduction. It's called refeeding. And this is usually after a prolonged starvation or a scarcity of food, okay? So malnutrition due to starvation or low food intake may give you, when you start feeding these people, the glucose may give you a syndrome, and this syndrome is called refeeding. The pathophysiological mechanisms remain unclear, but recent assumptions are based on the process that I'm going to describe. Anabolic process is initiated, okay? So when we introduce glucose, we introduce an anabolic process, okay? Anabolic process is we now utilize glucose instead of the other sources of glucose, like lipids and calories, like lipids and proteins. And this leads to intracellular glucose shift and water and electrolytes, resulting in potentially severe drop in serum micronutrient environment, okay? So we bring in glucose, and as soon as glucose is in the environment, everything is now taking glucose. The cells are now seeing glucose as a source of energy, and they are taking all the glucose and all the other nutrients into the cell. So the environment around the cell is devoid of these things, okay? There's severe electrolyte and fluid shifts that may result from refeeding after severe malnutrition, okay? So hypophosphatemia is the hallmark of refeeding syndrome, and due to the shift from fat to glucose metabolism, fat and protein metabolism. So what happens is when we introduce glucose into circulation, we start using the phosphorus to mobilize glucose for utilization. We phosphorylate glucose, and that removes the phosphate in circulation. Okay? That reduces the phosphate in circulation. Hypokalemia and hypomagnesemia occur. This reduced potassium and reduced phosphate lead to reduced energy. Okay, and this may be life-threatening. So the phosphate in circulation is reduced, for the potassium in circulation is reduced, and these are life-threatening. And this is the end of that talk. So now,
Thank you. Thank you, Dr. Wandolo, for the class, for your time.
good. So now we get to the chart. Yeah, I can see okay for the last one. Questions on this hyperalimentation. Nutritional support. Yeah, well, I did not put this as a complication. This is one very common complication of prolonged nutritional support. The GI tract atrophies when you stop using it. And when it atrophies, the bacteria find a way of going away from here. The majority of times, atrophic GI tract leads to septicemia. Most of the microbes that are in the GI tract translocate into the system. And we may get severe sepsis in people on prolonged parenteral nutrition. The majority of times, we put these people on prophylactic antibiotics. Beta Camuti. Hello? Beata or Beta? Beata Camuti. Hello? Hello, have I lost you people? Beata Camuti, did I get you the answer correctly? All right, now there was only one individual there, okay? What does phosphate and potassium reduce in refeeding? Or why? Okay. Now, the first thing, phosphate, as soon as we introduce glucose in an environment where glucose wasn't, we now start phosphorylating glucose. And the phosphorylation of glucose takes away the phosphate that is in circulation, the inorganic phosphate, that reduces the level of phosphate, okay? As we reduce phosphate, we reduce glucose, okay? The potassium reduces because glucose migrates into the cells. And as the glucose gets into the cells, we also get potassium getting into the cells, okay? So we get phosphate reduced because it is being used to phosphorylate glucose, and glucose moving into the cells because cells need it. We get also potassium going inside. So hypo, okay, you seem to have gotten the answer. Yeah. You don't want me to call your name. I can see that one. So I seem to have finished the questions on the chat. Are they finished?
Yes. Yes, Dr. Wandolo, they're done.
Oh, they are done, eh? Yes, okay. And everybody is satisfied with what we have done so far?
Yes, yes. It was a very well
Okay, so
detailed class.
I've finished these lectures.
Yes, we are complete now.
Yes, so there's a group in you that I'm teaching tomorrow. Yes, I don't know who the class rep for that group is.
Doc, that's me.
It is, who is it?
It's Patel.
Oh, you are Patel, eh?
Yeah.
No, I can't see you here, so let me see whether I can be able to see you. I don't know what I have done. I cannot be able to see that
You
whatever.
can stop the presentation first.
If I stop, then I can be able to see people.
Yeah.
Okay.
Recording
Okay,
stopped.
okay, even the recording has stopped. Eh?
Yes.
Who was that, Patel?
That was me. We have a session with you tomorrow from 9 to 11.
9 to 11, and this is about chemical tests on cardiac disease.
Yes.
Yeah, how do you go about this? You send me a link, or I normally give you a link?
I'll send you a link on your email.
No, I don't want to say you to send me a link. What I would like to do,
Yes.
I would like you to send me your email address or the class email address,
Yeah.
the group email address, and I'll send you the link.
Okay, fine. I've already messaged you.
You have already sent. You already
Yeah,
sent me a link.
No, I haven't sent you a link, but I just asked you how we're going to work it out.
Yeah. So what I will do,
Yeah.
I'll go to the Google Chat.
Yeah.
Yeah, I use that Google Chat for the morning. This one of yours here is for a big class. Eh?
No worries. No worries.
Okay, so I'll prepare this. I'll send it to you this evening so that you get the people
No
on
worries.
on board tomorrow morning. Eh?
Okay, no worries.
Okay.
Thank you.
This Ashil Patel, were you not there last time? What did I teach you last time?
We communicated last year.
Oh, I was teaching that big group, eh?
Yeah.
Or you still remember the glycogen storage disorders?
Yes, and liver function.
All right. Oh,
Yeah.
good. Now, I think I've finished the talk today.
No worries.
So we'll talk tomorrow with the other group, and this other group have finished the big group, eh?
Yes. Thank you.
Thank you. So now I can be able to get home, eh? Can leave the talk. You're going to send me the recording, eh?
No problem, doctor. I will send you the recording.
Okay.